So when we think about UV radiation in a basic sense, UVB is kind of easy to remember because UVB is responsible for most of our skin and sunburn, and UVA is responsible maybe more for our aging if we think about it in the old ways. And as I mentioned, UVB mostly causes skin burns, while UVA causes mostly aging. UVB, just like when we think about getting burnt more in the summer, is stronger in the summer, but UVA is actually constant pretty much all year round, even in the winter. UVA is 95% of our UV radiation, and UVB is only a small proportion. And UVB penetrates just the upper skin layers, whereas UVA penetrates very deeply. UVB is filtered by glass, like even in your car and things, but UVA can penetrate typical glass. So there are differences. But it's not as simple as just burning and aging. Both can actually cause skin damage and the problems associated with conditions like dermatomyositis. And there's been lots of research done on this related to the damage that both these forms of radiation can cause. And we have to remember that the UV intensity throughout the day changes, where midday UV radiation is greater in midday compared to first thing in the morning at the end of the night. And also UV intensity changes throughout the year. So winter months, there's much less red in this chart, showing much less UV intensity versus like May and July and so forth, where we have more UV intensity. To try to understand the severity or the extent of UV intensity, people have tried to make this UV index to try to give us a way to measure this. And you can find this in weather reports and on lots of apps and things like that and online. Usually we think of UV index of less than 2 as low, but above 5 is considered to be high. And I actually pulled this off of a website today, which actually shows the estimated UV index at noon today. So it was a high UV index a day throughout the U.S. and like Florida was somewhere in the 13s, so pretty high in most of the U.S. So hopefully everyone was using good sun protection today. You may have seen these kinds of charts before, and I know that working with lots of patients and parents with juvenile myositis, that patients and parents wind up being quite expert at UV protection and things like that. And I learned things from parents as well. But there is this general chart that actually Australians have put out, because there's a lot of issues with skin cancer in Australia. This is an interesting chart because it actually suggests on this chart that if the UV index is 1 or 2, no protection is required. If it's 3 to 7, protection required, seeking shade, putting on a shirt and sunscreen and a hat. And then maybe if it's above 8, trying to avoid being outside during the midday hours, and then skin protection on top of that. So that's an interesting chart, but I think it's important to know that perhaps with our kids who are more sun sensitive, this might not apply directly. So I think most of us know why sun protection is important in juvenile myositis, but we'll just walk through a couple of things. So as you know, kids with juvenile myositis can present with lots of weakness and fatigue and not being able to function as well as we would like them to. And then also lots of issues with rash, and they can present equally, or maybe one might be more prominent than the other. But as time goes by, as clinicians, we often see that we can improve the weakness remarkably with medications in many cases, but rashes can often persist, and that's a big issue. And that's because it really does seem that many of our patients with juvenile myositis have this thing called photosensitivity. And this has an interesting definition that was given by the American College of Rheumatology. and it's defined as a skin rash as a result of an unusual reaction to sunlight. And that actually just isn't limited to the skin. Even up to 72 hours after sun exposure, patients can present with fatigue and myalgia and arthralgia. So this term called photosensitivity doesn't have to just be skin involvement. And just going back to that UV index protection chart, I would say that maybe our kids with juvenile myositis, maybe you'd move these arrows a little bit differently. That maybe we'd say we always want protection for our kids, no matter what the UV index is. If we're outside with UV exposure, then maybe extra protection when others think it's just moderate protection. And then there are some cases where some patients and some children need extra protection continuously. And I think we really do find that all patients are different and individuals. And there are patients that really can't stand even 5 minutes in the sun. And there are patients who do okay with 50 minutes in the sun. But we're always careful with all of our patients, but in the patients who are extra photosensitive, taking extra precautions for sun protection is really important, no matter what the UV index is. And we know that in different research studies too, that I think Dr. Schiffenbauer will go into more detail, that what a patient's presenting features with dermatomyositis might be affected by sun exposure. If they flare, might be affected by sun exposure, and the severity of their disease might be affected by sun exposure. And there are different small research studies that suggest that this is true. So why else is sun protection important? Medicines that we suggest that patients take and they require to treat the condition can actually cause photosensitivity. Simple medicines like NSAIDs, like Motrin and naproxen, and the most common medicine we use in dermatomyositis, methotrexate, can actually make your skin more photosensitive. And of course, what we all worry about, skin cancer, which is the most common cause of cancer in the US, and 90% of skin cancer is actually caused by sun exposure. And then also aging. Aging is also an important thing, and this is something that sometimes helps encourage some of my teenage patients to use sunscreen more often. There is this very interesting photo that was published in the New England Journal of Medicine, and this really looks like someone who, it's a fake Photoshop picture, but in fact, this was a truck driver who drove for almost 30 years, where the left side of his face had lots of sun exposure over time, and the right side had less because it was not on the window exposed side, and you could see the amount of changes the sun caused him over the years. So these are all important reasons why avoiding sun exposure are important. So next we'll move just to some sun protection basics and sunscreen. And these are things I think that you all are familiar with too, but I think it's good to go over. And it's also important to know that our goal in treating kids with dermatomyositis and all conditions, all pediatric conditions, are really to try to have them function and play normally like other kids. But I think taking these precautions maybe can make it more possible. So avoiding and limiting the sun, and depending on what time of year it is and what part of the country it is, this is actually a pretty broad window, but limiting when possible. Otherwise, seeking shade when possible, using protective clothing like long sleeves and slacks, and thick weave UPF clothing that we'll go through on subsequent slides. Using a wide brimmed hat, and that's a hat that has a brim on the front and the sides and the back, and 3 inches is what is recommended, and wearing sunglasses. And then there's a lot of work we do related to sunscreen, because often all of these things aren't enough, it's also important to remember that when you're high up in the mountains or higher altitudes, you have more UV exposure. When you're near bodies of water, they actually reflect UV, so you get more UV exposure. So you have to be even more careful in those settings. And if you live closer to the equator as well. So how do you choose a sunscreen? And I think if you're thinking that I would tell you a magic sunscreen to use on this talk, I'm sorry, I'm going to disappoint you, because I think I really found that even if I think a sunscreen is great, some children will have some sun sensitivity or irritation to that sunscreen and so forth. So a lot of it related to specific brand is some trial and error, and then just some personal preferences as well. Thankfully, there's been a little bit more regulation related to sunscreens in the US, because you might notice that you don't see sunblock around anymore, because there's no such thing as a sunscreen that blocks 100% of the sun. So you won't see that terminology anymore. There is no such thing as a waterproof sunscreen. There's water resistant sunscreen, so labeling has changed. And originally sunscreen was meant to just block UVB rays, because only burning was thought to be important. But now there are new regulations related to how to assess for broad spectrum, meaning UVA and UVB blocking sunscreens. So which SPF is enough? So all this terminology is a little bit confusing, I think, to all of us. And I think, as I mentioned, historically, SPF only measured the amount of UVB a sunscreen would protect you from. And the amount of sunscreen you actually have to put on your skin to protect you at these levels are actually 2 milligrams per centimeter squared, which is more than you think it is. And we'll talk a little bit more about what the right amount of sunscreen is to apply to your skin on later slides. But when you think about SPF in general, if you weren't using any sunscreen and there were 100 beams of light coming down at you, you'd have all 100 beams of light coming down at you. If you actually use SPF 15 sunscreen at the appropriate doses or the appropriate amounts, you'd have 7 beams of sun or UVB coming down at you. If you use SPF 30, you'd have three beams coming down at you. So interestingly, you can never get to 100. So if you see SPF 100, it doesn't mean you're protected 100% of the time, or have 100% blocking from UV. So watch out for those. There's actually attempts to get rid of UV 100 and maybe make the cutoff closer to SPF 50 or 60. But at SPF 30, you really do get a very reasonable amount of protection at 97%. So spending extraordinary amounts of money on the higher SPF is usually not necessary. You have all probably seen different kinds of sunscreens, including like mineral sunscreens and chemical sunscreens. And mineral sunscreens actually reflect back the sun. And the most common ones that we see are zinc oxide and titanium dioxide. And chemical sunscreens have lots of interesting, complicated names. Probably oxybenzone is the most common one that's out on the market, and avobenzone. And those change the nature of the UVB to make them, and UVA to make them harmless. So when you get a bottle of sunscreen, what should you look for? You should look for something that says it's broad spectrum, which means it blocks UVA and UVB. You should look for SPF 30 or higher. And especially if you're going to be in any water activities, choose the water resistant or very water resistant type. And then how do you choose a sunscreen? There are so many different kinds around. It's very hard to decide what to choose. There's lots of creams and sticks and sprays. And I think sticking with what I mentioned on the previous slide about choosing a broad spectrum and greater than SPF 30 is the most important. I would also say that creams are preferred over sprays because just sprays are just very hard to measure how much you're applying, where creams you could see exactly how much you're applying and see where you're applying it. And a lot of times sprays and aerosol sprays, half of it will go in the air. So especially for the first application, I would suggest using creams over sprays. I know for the convenience of being outdoors and trying to chase your little ones around or big ones around to put sunscreen on them, sometimes the sprays are more convenient, and sometimes something is better than nothing. So what we mentioned before, SPF 30 at a minimum, reapplying every 2 hours. And I think this is a big challenge for everyone to succeed in, even as adults. I only applied my sunscreen once this morning and didn't reapply even though I was out all day. If you're out swimming, you should reapply every 40 minutes if you're getting wet. And then also a very important thing is that you have to apply the right amount of sunscreen. Most people only use about 1/4 of the recommended amount of sunscreen, and that actually makes sunscreen much less effective. It's also important to remember that sunscreens degrade, and leaving them out in the hot sun and in your car all day probably leads to degradation, and sunscreens also expire, so it's important to remember. So how much sunscreen is enough? And I learned a lot about this as I've been working with JM patients and patients in general over time, because I know I definitely haven't been using enough sunscreen in my years, because I can honestly say that a tube this big lasted me a whole summer 1 year. So how much should your typical 6-ounce tube last? So you could whisper these answers in your head. So a 6-ounce tube for an adult person should actually just last 6 applications. So if you were out all day long and were really applying sunscreen, then it would be a golf ball size or shot glass size amount, which is 1 ounce of sunscreen to apply on your full body. So that's a lot of sunscreen. And it's hard to estimate, actually. And for those of you who haven't been applying this much, it's actually much more than you think. So about a teaspoon in each area is what is recommended for an adult-sized person. Obviously, for a child, you'll make some adjustments to these estimates. So a teaspoon amount would be, if you were squirting sunscreen on your hand, it would be about the size of a nickel. And if you do this, your face will be definitely white after you apply the sunscreen on your face and your neck. And then you have to let it absorb for at least 15 or 20 minutes. So if you give this a try, it's actually surprising how much sunscreen it is. So I think it was eye-opening for me as I've worked with trying to be more consistent myself with sunscreen. So a question that came up through social media was, does he really need to wear sunscreen even if the UV index is low and it's a short exposure? And I think you might guess my answer from the previous slides too. I think it really depends. I think it depends because some kids are definitely more photosensitive than other kids. In general, it would be great if we could 100% of the time follow 100% of these recommendations for 100% of kids. But I think there are cases where some kids really aren't as photosensitive, that if it really is a low exposure and you're walking from one shop to another and it's just a couple of minutes of exposure in between, maybe you don't have to have that argument or disagreement with your child to apply all the sunscreen and things like that. But I think it really depends. And in the perfect world, it would be in all cases, but we have to live with reality. Okay. Another question that came up through social media was, when getting too much sun and you end up with hives and blisters on top of a rash, what is the best remedy to use? And the easy answer is, again, it depends. And the easy answer is, try really to avoid getting the rash and sun exposure to start with. And supportive care is actually what's best for people with these things. And cold compresses, soaks, calamine lotion, and aloe are helpful for many people just for the soothing effect that you can have. Cleaning the area and covering it with wet dressings, especially if it's blistering. And over-the-counter pain relievers like Tylenol and ibuprofen help. Things like steroids actually are found not to help these things. Also, it's important that it could be that the blistering or rash is actually a JM rash and not just, quote, just a sunburn. So connecting with your rheumatologist to discuss that is also important, and taking photos to show them later on if they're not available right away. So the next question, another question that came up was, is sunblock sufficient? Should our kids always wear long sleeves and pants? And we kind of answered some of that before too. And that brings us to this idea of UPF and SPF. So I think many of you have heard of UPF. So UPF stands for ultraviolet protection factor, and it measures the fabric's ability to block UVA and UVB rays. There's a bigger assortment of these kinds of clothes in sporting goods stores and in bathing suits and in swim shirts and things like that. And these UPF ratings actually mirror a lot of SPF ratings. So UPF 15 is about 93% protection, and this actually is blocking UVA and UVB rays. UPF 50 is about 98% blockage. But obviously not all our clothes have UPF ratings. And when we think about our regular clothes in general, thicker fabrics or dense constructed fabrics are better at blocking sun. Darker fabrics are actually better than lighter fabrics at blocking sun because of, or UV, because some of the dyes actually absorb some of the UV, and the material actually matters. They've done testing on these kinds of things, and Lycra and plastics and a lot of things like swim shirts and things like that are made out of, have actually better UPF ratings than other things like regular cotton and linen and things like that. And just to give you a general idea, thick jeans actually have a great UPF rating of over 50. A white t-shirt has an extraordinarily low UPF rating. It has a UPF rating of like 3 or 5. You might as well go out without a shirt in that case. There is actually this item called SunGuard that some of you might have heard of. It's a product that you can use to wash in with your clothes that puts a chemical into the clothes that gives clothes about a UPF 30 rating and lasts about 20 washes. And I've heard very good feedback from patients about this. So I'm going to move on to a couple of true or false questions, and hopefully you can answer some of these based on what we talked about. True or false? When it is hot out, I need to use more sun protective measures. So when I'm at the beach versus when I'm out skiing. Okay, so hopefully you guys have come up with an answer. So the answer is false. The heat you actually feel from the sun isn't from UV at all. UV you can't see or feel. And on top of a mountain, I think maybe some of you guys have experienced this with skiing. You might come back with a terrible sunburn that might be as bad or worse than if you got it at the beach. So please remember, it's not just sun or heat that predicts how much UV exposure you'll have. Okay, so true or false, if I put sunscreen in the morning, I'm set for the day. And I kind of gave this away because I told you what I didn't do today. And it's false. You really do need to reapply your sunscreen, whether it's a chemical or a mineral sunscreen, every 2 hours or so to be fully protected. And true or false, SPF 60 is 2 times stronger than SPF 30, and SPF 100 protects me 100% from UV radiation. So yeah, we talked about this already, so that's not true at all. SPF, there is no sunscreen that gives you 100% protection. Okay, let's say you're trying to save, you're running out of sunscreen, you have SPF 100. So let's use half the recommended amount of sunscreen, and you have SPF 100, maybe I'll save some money, and it'll be SPF 50 then. Sounds like a great idea. But actually it's not true. If you use half of the amount of sunscreen of SPF 100, it'll actually only be as good as SPF 10. So that's important to keep in mind. I need less sunscreen on a cloudy day. And this was a question that came up through social media. Should it be applied even when it's not sunny? And you do need to apply even on cloudy days, because over 80% of UVA passes through the clouds. Even if UVB is a bit covered, UVA is still passing through the clouds and is responsible for sun-related damage. I don't need sunscreen if I'm indoors. Is that true or false? So maybe, so some houses have lots of windows and you have a lot of sun exposure there. And remember, UVA passes through windows and glass. And I have seen children have exposure, be very photosensitive and have enough exposure just through their windows to cause concern. And here's a good one. I have some darker skinned patients and that think that they're protected from the sun, and some teenage patients that think if they get a tan and go to tanning beds, that maybe they'll be a little more protected from the sun. Does a little tan protect me from the sun? Unfortunately, it doesn't. It might give you an SPF of 3, but that's like a useless SPF. You might as well not have that. And anytime your body gets a tan, your skin is actually showing that it's stressed and getting damaged. So I hope I learned a lot from those questions. I hope you guys did too. A few other things to consider. Artificial light, and this came up through questions through social media as well. Artificial light is an important thing to think about, actually, and it's becoming less of a problem, thankfully, because of attempts at energy efficiency and more use of LED lights. Compact fluorescent lights actually have wavelengths that can cause photosensitivity and are in the UV range, but LED lights are much lower. Energy efficient halogen lights are somewhere in between. So, so we give a green light to LED lights or light emitting diodes. We give a red or no-go to compact fluorescent lights, and somewhere in between for the energy efficient halogen lights. I have had cases where some old schools still had some compact fluorescent lights and was causing problems with some of my patients who were photosensitive. So if you guys do notice things like that, then it might be something to ask your school about. And then I thought I'd just go through some surprising sources of UV, where you know, nail salons and those machines that they use actually use UV light. Tanning beds use UV light. Be careful. I've had kids who flared their rash on their fingers related to these kinds of things. And then a few more things. Don't forget your vitamin D. Sunlight is a very important source of vitamin D, and we're blocking a lot of that production through use of all the sun protection. So vitamin D supplementation is really important in all of us. So this is, I think, my concluding slide. Sun protection. It's important for everyone's health, but especially for our kids who are sun sensitive and have juvenile dermatomyositis. And these are general tips about avoiding or limiting the sun, using physical blockers when possible and shade when possible, using protective clothing with long sleeves and slacks, or thick weave clothing with UPF and wide brimmed hats, and wearing sunglasses, and using sunscreen, rain or shine, using SPF 30 or higher, and use the right amount, and try to practice what a teaspoon looks like. Apply 20 minutes or earlier before you're going outdoors, or applying every 2 hours or more often if you get wet. And yeah, I think that's my concluding slide. Thanks very much for your attention. I think I'll pass it over to Adam now.
So hi, I'm Adam Schiffenbauer. I'm an adult rheumatologist over at the National Institutes of Health, and I'm really excited to be here to give this talk along with Dr. Kim on skin disease and skin protection. Probably my biggest disclosure is I'm an adult rheumatologist, not a pediatric rheumatologist, but we see plenty of children through our clinic and through our ongoing efforts here. So the first thing I wanted to talk about is something that we've heard about from a lot of our patients who've been reading about this in various newspapers. So on May 6th, there was a research paper that came out that showed that 4 particular sunscreen ingredients were found in the blood of patients who were using sunscreen. So they used 4 different sunscreens, spray, 2 sprays, a cream, and an ointment. And they showed that the chemicals in those sunscreens were showing up in patients' blood and in the popular press and different newspapers and journal articles and stuff that came out saying, oh, there's toxicity from sunscreen, it's showing up in these blood. These patients were applied. Yeah.
Oh, I think that you did the same thing I did, that you didn't start the sharing. Did you start sharing?
Well, I hope so. Let me see. Nope. Oh, no, you're right. They made that tricky. Let's see.
Yeah, 2 steps, right?
2 steps.
Yeah.
All right, now are we good?
Good.
All right. Disclosures. So there we go. So they did, for this study, they did apply sunscreen the way it was supposed to be applied per the package. So they applied it 4 times a day for 4 days in a row, and they put over 75% of the people's body, and with the idea that that's everything a bathing suit wouldn't cover. And like I said, they found 4 of the chemicals at different concentrations based off of the type of sunscreen. So not every sunscreen has every chemical in it. So some of the sunscreens didn't show up with those in the bloodstream of those participants. And the idea is the FDA has put out some guidelines saying that anything that gets into the blood at a concentration greater than 0.5 nanograms per milliliter should be further evaluated for toxicity. And for these 4 particular compounds, there isn't really known toxicity data. There's nothing that anyone's particularly alarmed about or concerned, but there isn't that toxicity data, so this would promote them to be further studied. There have been similar studies back all the way to 2006, showing that sunscreen, if you used it in a reasonable amount way, got absorbed into the blood and was showing up in patients' blood tests. And the general feeling from the community was that it's okay, that none of these things are likely to be particularly toxic. There was nothing based off of their structures that was particularly worrisome, and everyone should keep using sunscreen. And I think that's probably where we will end up again. And I wouldn't tell anyone to stop using chemical sunscreen. But if you're particularly concerned, the solution is not to stop using sunscreen, it's to use those mineral-based sunscreens, the zinc oxide or the titanium dioxide. And those have had that extra level of FDA toxicity testing where they've shown to be non-toxic and okay to use. So those are, if you're particularly worried about the chemicals based off of what's been showing up in the press, and the answer is don't stop using the sunscreen, just switch over, and all the labels will tell you which zinc oxide or titanium dioxide type sunscreen. Those used to be pretty oily, and our pediatric patients complain about them, but there are newer formulations that are a lot better. People seem to appreciate and not have as many issues with. So I was going to talk about targeting the skin disease, so the other side of managing the patients with a rash. So certainly JDM, as we all know, can present with skin disease as the major manifestation. So either muscle disease with skin disease, where the muscle disease is relatively minor and the skin disease is quite severe, or where really there's almost no muscle disease and the skin disease is quite severe. And as Dr. Kim said, it's not uncommon that we treat patients with juvenile dermatomyositis and we have a good response to treatment for their muscle disease, but the skin disease isn't quite under control. And for a lot of the parts of myositis, we tend to think if we treat it, everything sort of goes together. Muscle, lung, other organs all either get better together or get worse together, but skin really can lag behind. We can get the muscle under good control with the skin disease still being relatively active. So there have been some guidelines in this area. So the SHARE group, which is a European consortium, it's an initiative started in 2012. It stands for the Very Creative Single Hub and Access Point for Rheumatology in Europe. So it's a European group, but their statements on this were that ongoing skin disease reflects ongoing systemic disease and should be treated with increasing systemic immunosuppression. But then they also go on to advocate for topical treatment with tacrolimus and steroids for some skin disease. And I think this reflects part of how we think about skin disease, that certainly very active skin disease is a marker that perhaps there are other things going on. There's muscle disease to be concerned about. And skin disease can certainly be severe enough that systemic therapy is warranted, that an increase in baseline immunosuppression is needed in order to control it. And that sometimes can be problematic. And often this shows up in patients where it's quite difficult to get their muscle disease under control. A regimen finally works for that, but the skin disease is still mildly active. And there's a question of what do you do in that standpoint? Do you risk sort of changing the baseline regimen and maybe not controlling the muscle, or do you sort of let the skin disease go? And it's one of the harder things to solve, and we'll talk about some of those treatments. Sun protection is certainly important, as you just heard, but not just for the skin disease, but also the muscle disease. There are lots of patients who, when they're out and get significant sun exposure, will get weakness, their muscle enzymes will go up, their disease will flare, so patients will have disease flares that don't simply stop when they're removed from the sun, but are ongoing and require additional therapy after significant UV exposure. And it's an important thing to think about. So it's not just I'm going to have a rash if I'm out in the sun for a little bit, but it really can make the disease overall worse and more active. There's no great predictor. So a lot of people ask about predictors for sun sensitivity, and there's no great predictor for who's going to be more sensitive or not in JDM patients. Certainly those who don't have skin involvement are less likely to be photosensitive, and therefore the autoantibodies that go with having more skin disease tend to be associated with being more photosensitive, but there's not a great answer here. And most patients seem to figure out how sensitive they are pretty fast. It's hard to avoid the sun all the time, even with best intentions, and they figure out how much they pay for it when they're out in the sun. So one of the first medications I was going to talk about is hydroxychloroquine. So there was a prior very good webinar on the Cure JM site about medication overall and treatment of JDM. So I'm not going to cover everything, but I'm going to try and go through the things that we think of as being more for skin disease. So hydroxychloroquine is an oral pill. It was originally used for malaria. It's still used for malaria, and it's used in combination therapy. It doesn't have a lot of the common side effects of immunosuppressive medication, and it's not a particularly potent medication, but it helps in those settings where somebody is on a regimen, their muscle disease is doing well, but that skin disease is sort of still there, still a little active. It will help with the muscle disease some, and giving it can sort of give that push over the edge to get that skin disease under control and get it better. The two side effects we worry about with hydroxychloroquine have to do with the fact that it's a dye. So it can get into your skin and change the color of some patient's skin, either making it a little darker or giving it a bluish tinge. And then the one that we're more concerned about is it can get into the eye and cause vision problems. That's why there's routine eye exam scheduled for this, because it can be seen on the eye prior to those vision changes occurring. And when an ophthalmologist sees this in the eye, then the medication is stopped. and you can stop it prior to developing the vision problems that we are concerned about. It's a relatively safe medication, and it can help in skin disease, and that's where we tend to use it. Next thing I'd talk about is topical steroids that can certainly help in the management of focal areas of skin disease. Again, if there's widespread rash that's quite severe, probably going to systemic therapy and changes there is more important. And we end up with patients who are on topical steroids with several formulations often. So different strengths and consistencies can be used, and it's not uncommon that patients will have, 3 different topical steroids they're using, a shampoo for their hair to make that tolerable and a fine texture, sort of a more mellow, less potent steroid for the face, and then maybe a more aggressive steroid with a higher potency for the body and rash on the body. And certainly getting those in the right parts of the body and used in the right way is important. Part of that has to do with the side effects and the systemic absorption. So in children, we tend not to use the high potency steroids over concerns about that. So we're talking predominantly about low and medium potency steroids. In those patients. The side effects can involve changes to the skin, skin thickening, skin rash, both an irritated rash, some acne-like rash can develop. Patients can get some blood vessels that appear in the skin there that can be unpleasant looking. And then there's systemic absorption of steroids. So particularly if patients are on a lot of topical steroids, they can be getting that into the blood. They can be getting benefits as if they were taking a low-dose oral steroid or getting that on top of their low-dose oral steroid. And it's not uncommon that patients will stop a large amount of topical steroid because they're doing well and discover that overall their symptoms may get worse because they were getting some of that absorption to the general part of the body. It's one of the things we worry about, that patients can get suppression of their normal steroid production from topical steroids again if they have a large amount of topical steroids for a prolonged period of time. There are other things we worry about for topical steroids based on particular locations. So there are particular side effects if it gets into the eyes and using it around the eyes to be concerned about. And if you're going to do it on the face near the eyes, certainly talking to your dermatologist or whoever's prescribing the steroids is important to know what those side effects are. And then something we often don't talk about, but is important to know about, is that you can get a rash after the steroids. So maybe a week or two to longer after the steroids are stopped, there's a rash that can occur. There can be some pain associated with it. It's usually associated with steroid use in genital regions, but areas where there's thin skin in general can get that. And it's just something to be aware of if you've been using topical steroids for a prolonged period and then stop it. One of the next set of agents that I'm going to talk about is topical sirolimus and tacrolimus, both of which have been used quite extensively for controlling the skin manifestations of myositis. They don't have a lot of the side effects of topical steroids, particularly that skin thinning that people tend not to like, and they don't have the same systemic absorption issue of interacting with the steroids. They can be relatively potent therapy for skin disease. And we've seen very good response in some patients who don't respond even to sort of the low-dose steroids. And the side effects here, like I said, are different. Again, skin rashes certainly occur. There's chance of worsening skin infection. So if you have a skin infection in that area, not using topical sirolimus or tacrolimus is a good decision until those are cleared up, and they can bring on some skin infections. And then there are reports of skin cancer. Most people would avoid using these in an area of skin where there's something that's concerning. So there's a part of the skin where you're concerned that maybe something's precancerous, or there's a mole or something that looks just a little off-putting. Avoiding the sirolimus and tacrolimus there is important, and you certainly should discuss that with your physician if you were going to do it. But those are the main concerns from those medications, and they can be quite good at treating that topical disease. So I wanted to talk about 2 therapies that are on the way or coming up. So one is lenabosum. So there are currently adult trials ongoing for lenabosum. It's an oral therapy that goes through a different mechanism. And currently the trials for adult dermatomyositis, there hasn't been any reports for trials for juvenile dermatomyositis. but certainly one would expect that if this was approved, people would use it off-label in pediatric patients, and that there would be interest in doing a study in that population, as many medications start in the adults and move to pediatric patients. And it's being assessed for skin treatment. So this is a predominantly skin treating disease. We really don't have a lot of data about how it does for manifestations of myositis beyond the skin. And it's thought to reduce inflammation and fibrosis. So the current ongoing studies are not just for adult dermatomyositis, but also for scleroderma and cystic fibrosis. And those are mostly from the fibrosis standpoint. The common side effects that they describe so far are dry mouth, dizziness, and fatigue. And one of the big advantages here is that it can be taken simultaneously with other therapies. So you see lots of drug studies that will say for juvenile dermatomyositis or anything that we want patients to be off of other medications or have a washout period. And here really the answer is you take whatever you're on and you take this. And that's a real big advantage because it solves that problem that we talked about where you're on a therapy that works really well for muscle disease and it's taken a long time to get there and to get a patient stable. And then the skin disease is a little active, or not even a little active, moderately active. And there's a real discussion about whether it's worth upsetting that balance and changing everything in order to treat the skin disease, or whether we keep going with what's on and sort of accept the skin disease is going to be active. I advocate against that, but I know that's a hard decision when faced with that situation, particularly if you're not on first-line therapies but have tried several things. And this has the advantage that you can use it with that thing. So whatever you're taking that has the muscle disease under control, when the muscle disease is doing well, if skin disease isn't, this is something people will be able to try on top of it. So I think it's coming. We'll see how the studies go for adult dermatomyositis, but I think it's worth talking about because it's going to be out there in the near future, most likely, as we go forward. And then the other thing that we've seen a lot of conversation about recently are the Jak inhibitors. So certainly we're seeing them used off-label for adult and juvenile myositis, both JDM and JPM. And there was a very nice recent study of 4 patients presented at the Global Conference on Myositis by Dr. Hannah-Kim, and it showed a drop in the CDASI from a mean of 42 to 27. So the CDASI is a way to assess skin disease. It's a tool that physicians can use, and 42 to 27 is a pretty significant decrease in skin disease. So that's a mean CDASI improvement of 35% in that group. And that's more than we would normally talk about for a lot of these medications. And it puts forth the idea that the Jak inhibitors may be better at treating skin disease than some of the other immunosuppressants that we normally use. Certainly those are going to require bigger studies, and it's not something people are advocating for right now for a first-line therapy, so not replacing the methotrexate, azathioprine, or cyclosporin, or Celsip that we normally use now, but potentially in the future with more information, this may be something where we say somebody who has very severe skin disease, this might be a medication used earlier. This is an or medication, so it's not you take what you're taking now and you take a Jak inhibitor. It's that you switch your immunosuppressive baseline medication to a Jak inhibitor. So switching that azathioprine, methotrexate, Celsip to one of the Jak inhibitors, with the idea that it would treat both the skin and the muscle disease. The side effects are similar to a lot of the other anti-inflammatory medications that we talk about and use frequently in juvenile myositis, the risk of infection and the risk of malignancy. The other risk that's particular to this is a risk of pulmonary embolus. It's only been shown in rheumatoid arthritis patients and at a higher dose, but there's more information to learn there. So I think we're seeing more and more patients on this. It's something that your physician may think about or try. If you haven't, your patient hasn't responded well to other things and has pretty significant skin disease. And I think we'll be seeing more studies looking at the Jak inhibitors in the adult and pediatric populations coming up. And I think those will be very telling for us about where they fit in therapy, whether this is something that comes after you've failed other therapy, or whether this might be a first-line oral medication that we can use to treat patients. So the other area that I wanted to touch on some is calcinosis, because it's important, and we often think of it as connected with the skin disease. It's important because it shows up in about 35% of our JDM patients. And there's evidence that it's associated with worse physical function. We don't have a great way to treat it now. We don't have great evidence for what we do use to treat it, but it impacts our patients, and it's important for us to at least think about. So the treatments for calcinosis really fall under 3 categories: anti-inflammatory management, medications targeting the calcium or the calcinosis itself, and then the mechanical measures, which are predominantly surgery. So treating inflammation treats calcinosis, helps prevent it, has been sort of the mantra that we go with, but there's certain drugs that seem to do better at preventing calcinosis and treating it. So there have been case reports and case series for IVIG. There's a very nice case report for abatacept in this use. Our colleagues across the pond in Europe have been using a lot of thalidomide recently in these patients, and have been saying they've been having good results. Based off of the inflammatory markers that we see in these patients, the infliximab and the anti-TNF medications seem promising. Because of the crystals that deposit from that calcium deposition, treating it like a medication, like we would treat gout or other crystal diseases, seems to make sense. So people have tried using colchicine, anakinra, and there are good reports for anakinra for calcinosis and some other autoimmune disorders. And then the JAK kinase inhibitors have been being used most recently, again with the idea that they might be very good for skin disease and therefore very good for calcinosis as a complication of skin disease. In terms of medications that treat the calcinosis itself, bisphosphonates are probably the most commonly used. In the pediatric population, there are certain risks, and we have to talk about those. But the bisphosphonates, pinidronate, etidronate, lonidronate, zoledronic acid are probably what's most commonly used these days. Sodium thiosulfate has been used in their case series and case reports for that, being given both IV or topically as well as intralesional injections. We have an ongoing drug study for IV sodium thiosulfate in adult and pediatric patients here at NIH, trying to treat calcinosis in DM and JDM. Aluminum hydroxide was used, not used as much anymore. Same thing for probenecid. The calcium channel blockers had looked very promising when they were first started to be used, but have become less commonly used over time. And treprostinil is probably the newest one that we're talking about in this block. In the scleroderma population, they used it to treat pulmonary hypertension and saw as a side effect that calcinosis seemed to get better. And those studies are underway, and we hope to see more out of those in the scleroderma population. There was a while where Coumadin, warfarin was thought to be used. It might be helpful. That really hasn't panned out, and sort of we advise against using that for calcinosis. And then the final section would be mechanical measures. So we certainly have lots of reports of patients who develop calcinosis in areas of microtrauma. So that's not a car accident, being hit by a large beam. That's you bump your elbow or your arm a lot. You carry something that sits on that part of your body. And using the cushioning to try and prevent that microtrauma, to try and prevent the calcinosis is important. Surgical resection is an area where there's debate. We see a lot of patients where they have surgical resection and then have recurrence of the calcinosis very quickly in the same area, often more severe. It's something most physicians hold off on unless there's true limits to activity, so it's affecting quality of life in an important way, or it's crossing a joint and we worry about contractures and other problems from that. Lithotripsy was used more in the past. There's a Japanese group that's having good results with lithotripsy currently. Carbon dioxide laser therapy has been using, and hyperbaric oxygen has been tried. There haven't been great cases of it being particularly successful, but it is used to try and treat calcinosis. And this is just an idea. This is from the CARA survey from 2017, seeing what pediatric rheumatologists really were using. And you can see very few of them are suggesting surgery as a first-line therapy, although many will use surgery, and most are suggesting increases in immunosuppression as first-line therapy. You can see the high use of bisphosphonates and the calcium channel blockers, as well as the sodium thiosulfate, and you'll see the Coumadin and warfarin missing from that list because it's not widely used. Same thing in the anti-inflammatory agents. The IVIG is heavily used. And then the big thing is you can look and see the colchicine, which we normally don't talk about so much for myositis, being used quite extensively in patients where we're trying to target the calcinosis with the idea it's more helpful. And then the thalidomide up at 6% is not a high percentage, but probably higher than you would see in non-calcinosis patients. So suggesting some experience there and that physicians are using this to try and treat dermatomyositis with calcinosis. So I want to thank the group for having us to give this talk today, as well as all the fine folks I work with, many of whom are pediatric rheumatologists, who I get the pleasure of seeing kids with, and teach me a whole lot about what we're doing. It's one of the nice parts here, that we have adult and pediatric folks. We all get to learn from each other. So I wanted to hand this back over to our hosts from Kira JM, and they can take it away here.